Very happy to have our speaker here today. Jeff Singer is a practicing surgeon, a senior fellow in health policy studies at the Cato Institute, and he's the author of a recent book, Your Body, Your Healthcare, which he has on hand to promote. We will be doing our usual book draw today, and so we will post a link to that book draw during the talk and hope that you will enter that book draw. One of you will get a copy absolutely free of charge. For those of you who don't get a free copy, you can purchase one on the free market because unlike healthcare, in books, we have a pretty free market, and there's lots of places where you can get a book without even needing to sit on a waiting list or get anyone's approval to buy that book. Jeff's talk today is going to be explaining how the systems in Canada and the US compare, what their similarities reveal about both governments, the limits both governments place on our choice. And as Jeff and I have been talking about this, one thing I think is that both Canadians and Americans think we have very different healthcare systems. Of course, there are differences between our systems, but as Jeff will be explaining today, the systems may be more similar than you think. With that, Jeff, I will pass it over to you. Thanks again for joining us today.
Well, thanks, Matt, and it's a pleasure to be here. I'm really looking forward to this opportunity to talk about this because in both the U.S. and Canada, people think that the Canadians have socialized medicine, and in the United States, we have free market medicine. And Canadians think that people just they can go anywhere they want to get healthcare as long as they have their American Express card with them. And Americans think that what they have is free market healthcare. And when people suggest further government interventions, they say, don't mess our free market healthcare. So actually, we have a lot in common. Both the U.S. and Canada. Now, let's start off with how we pay for healthcare, because there are other ways we're also similar. Both the U.S. and Canada have socialized medicine. I keep telling my American friends that we have socialized medicine here in the United States. It's just that the U.S. version is a patchwork of different government-run models all stitched together, whereas the Canadian system is one simple, kind of cleaner model. So, for example, let's start with Canada. Canada has 40 million people, roughly, and the federal government of Canada block grants money to the provinces, and the provinces make up the rest. And they have a single payer system. So as a rule, outpatient prescription drugs are not covered as a general rule. But there's a block grant. And so there's only so much money that the federal government's going to give to the province per year. And then it's up to the province if they want to add to that. In the US, we have 70 million people who are categorized as earning less than or equal to 138% roughly of the federal poverty level. And the federal government pays an average of 65 to 75% of the bill, and the states pay the rest. We call that Medicaid. And so the federal government and the state governments are sort of partners, but the federal government pays roughly 65 to 75% of the bill. But it's not block granted. It's open-ended. It's just matching funds. So and outpatient drugs are covered. So basically, the more that the people in a given state utilize Medicaid, the greater the contribution the federal government needs to kick in because there's more money being spent. So Canada essentially tells provinces, the government in Ottawa essentially tells provinces, here's your check, spend it wisely, while Medicaid tells states, spend more and we'll help you pay for it. And that difference matters because Canada constrains spending through fixed budgets, often showing up as lines, cues, while Medicaid's open-ended match encourages higher spending and shifts more of the fiscal burden to the federal government. Well, that accounts for roughly 20% of the U.S. population. We've already compared 70 million Americans to 40 million Canadians, but there's another roughly 20% of the U.S. population, which is people over the age of 65. And in the U.S., they're on Medicare. There's no private health insurance available to them. They have to enroll in Medicare, which is a government funded and run system. It's a single payer system. And Medicare goes further than Medicaid. It's open-ended with the federal government, not the states, automatically covering costs as they rise. So it's all on the federal government, even when in certain instances, private insurers are contracted to administer parts of the Medicare program. So to kind of summarize, Canada caps the federal contribution. The U.S. Medicaid system shares the costs with the states, and U.S. Medicare just pays the whole bill. So now we've covered around 40% of the population. Now, about 3% of Americans are in the Veterans Health Affairs system, which is analogous to the UK's National Health Service. So the government owns and operates the hospitals and health facilities. It also employs all of the doctors, nurses, and other staff. And the care to the veterans is free, or depending on their level of military service, whether they were in combat or not, et cetera, there may be certain fees, but generally it's free. And that's about 3% of the U.S. population. And a little bit under 1% of the U.S. population are indigenous peoples who are eligible to participate in the Indian Health Service, which again is like the National Health Service in the UK, where it's government owned and operated facilities with government employed staff, and there's no out of pocket to the people who use it. So now we got, what's that, roughly 43% or so of the US population. Now roughly 50% of the population receive their health insurance in a different way. We have a tax code that basically makes it that employers take control of a portion of what otherwise would have been an employee's compensation. They control that money and use that money to purchase a health insurance plan of their choosing. So instead of the employee being able to decide whether or not they want to buy health insurance, the employer, in lieu of income, in lieu of compensation, buys this health insurance. Because in the U.S., employer-provided health insurance is a tax-exempt benefit. You don't pay tax. If your employer provided you, let's say, with life insurance, you pay income tax on that as a compensation. But health insurance is tax excluded, and it's also a tax deduction for the employer. In addition, ever since the Affordable Care Act was passed, any employer of more than 50 employees must buy this insurance. So they're basically required by the federal government to take control of a portion of the employee's income that they otherwise would have and use their judgment to purchase health insurance for them that is not portable. So if they leave their job for whatever reason, they can't take their insurance with them. Now they're uninsured until they get another form of insurance. But also, the government has all sorts of requirements on what that employer's insurance must provide. So, for example, it can not have any annual or lifetime dollar limits on covered services. All preventive services such as endoscopies, immunizations, and other wellness preventive care, there's no cost sharing. In other words, the insurance that the employee has, they don't have to pay out of pocket. Of course, people who watch these events at ILS know that there's no such thing as a free lunch. So, in lieu of you paying it, you pay it in the form of a premium. And employers also do make their employees pay for at least a portion of the premium, which is deducted from their paycheck. And also, this insurance has to cover dependents up till age 26. So, if your kids are in college, even when they graduate college, they're covered by the employee's insurance plan, which is provided by the employer until they're 26, unless they get a job that gives them insurance and they don't need it anymore. Now, other large employers can self-insure under another law called ERISA, E-R-I-S-A, or the Employee Retirement Income Security Act, which is administered not by the Department of Health and Human Services, but by the U.S. Department of Labor. And under ERISA, there's still certain requirements as to what must be covered, but it's much more liberal. A lot more freedom is left to the employer to decide what that coverage is going to be, and they're exempt from state mandates, because in addition to the federal government, a lot of states have additional mandates they require of health insurance companies in their states. So if you're self-insured under ERISA, you're immune to those state mandates. Now, we've covered about 90% of Americans. Okay. So next, we got about the 10% remaining who don't get insurance through their employer or are not on Medicaid or Medicare or going to the VA system or Indian Health Service. They need to go get individual health insurance. And they get their individual health insurance through a government-run health insurance exchange. And in order to be on the exchange, the insurance company has to basically sell a federal government designed product, which has what's called essential health benefits in it. So in other words, our political representatives in Washington have decided what each of us as individuals needs for health insurance coverage. And they decided that, for example, even though a 30-year-old male may be single, he still has to get maternity benefits coverage. So that's among the list of essential health benefits. Addiction rehab services. I'm just giving a couple of examples. And also, the government has decided that this health insurance can't charge, has to accept every applicant, can't turn them down if they're a bad risk, like other types of insurance might do, and can't adjust the premium to fit the risk. So in other words, it's called community rating as opposed to risk adjusted rating. So under this model, let's say you're a 30-year-old IV drug user who's HIV positive and hepatitis C positive. You can't be charged a premium any different than a 30-year-old non-smoker, non-drinker triathlete. You both are charged the same premium, which obviously means that even though the second person I spoke to might have had a low premium and the first person I mentioned might have had a very high premium, the insurance company's got to manage the money, basically, so they have to come up with something somewhere in between that would cover the expenses expected from the sicker person. And so that's the way the insurance is designed by the government. It's available to everybody. Now, this insurance, therefore, is very expensive because the insurance companies aren't given a lot of leeway in terms. Also, it requires that there's no out-of-pocket expense for wellness, for preventative care and that kind of thing. So the insurance companies, you would think, with those kind of requirements, would have even if people choose a high deductible, and the federal government does have restrictions on ranges of deductibles too. Even if you choose a high deductible, it's still going to be very expensive. So the federal government comes in and subsidizes people who are buying their individual insurance through the government-run exchange, because the politicians knew that people wouldn't be able to afford this insurance they've designed for them. So, and the way that they call this subsidy in an Orwellian fashion, a tax credit. So, my understanding of a tax credit would be if I pay my income tax and there's something that entitles me to credit, so I get a check back from the government on taxes that I had paid, or maybe I could deduct it from the amount I owe them. But the way this works is, regardless of how much income tax you've paid, even if you've paid none, you get a tax credit, because that sounds much better than saying subsidy. And that credit goes directly to the insurance company. So you never see it. You may not even know what it is. So, and this tax credit is on a sliding scale. So the higher the income level, the lower the tax credit, which means the greater the proportion of this premium you're going to have to pay. So roughly speaking, and this changes from year to year, a family of four in the U.S. earning around $47,000 a year gets a 100% subsidy of their premium. So they pay no premium. So they go on this government-run exchange, they purchase a product that they may not even want because they may have a lot of things that they're not interested in, but they have to purchase it, and then they don't even see the premium, and because that's all paid directly from the federal government to the insurance company that's handling the insurance. And that subsidy decreases to the point where roughly a family of four earning between $160,000 to $200,000 a year starts to see the subsidy disappear, and they have to actually pay the entire price. And during, you probably heard about this big controversy in the United States that led to a government shutdown back around August, September of 25, because during the Biden administration, due to COVID, as an emergency measure, Congress passed an extension of that subsidy so that a family of four earning as much as $600,000 a year got a subsidy to buy this insurance. But that expired last year. And the big battle was over extending it or not. And it turns out it didn't get extended. So now the subsidy disappears once again at between 160 to 200,000 a year. So basically, between this government designed individual insurance, which people obtain through a government exchange, and the insurance companies aren't really selling insurance; they're basically just administrating the government plan. You got that. You got the government designed employer provided insurance where the employer is required to purchase or design a health insurance plan for their employee using what otherwise would have been their employee's compensation. That's not portable. Then you have Medicare, which is basically the exact same thing as it's not even. It's a open-ended blank check from the federal government to pay for health care, no limits for seniors. And then you got Medicaid, which more closely approximates the Canadian system for people who earn 138% or less of the federal poverty level, except unlike the Canadian system, it's not block granted, so there's no limits as to how much money can be spent, and it just keeps weighing on the federal budget. So out of that, you have about 7% of Americans who don't have health insurance. And the only reason they don't have health insurance is because they choose not to, because maybe they don't want to buy the insurance that's being offered by the government-run exchanges, and so they just decide not to. They rather keep the money in their pockets. But it doesn't matter, because if they were to get sick, they could then enroll during the open enrollment period in that government-run insurance, because it's what they call guaranteed issue. The federal government doesn't allow the insurance company to turn them down. So it kind of makes sense, like unless you get sick between the open enrollments, that's a bad time to get sick. But it kind of makes sense that, for example, why don't I just keep my money and enjoy it? And then if I come down with, a heart condition, well, then I'll go and enroll in the insurance. They can't turn me down because of my heart condition, and they can't charge me any differently than if I didn't have a heart condition. So that's when I'll do it. Sort of like, if you imagine this for auto insurance, it wouldn't make any sense to buy auto insurance under those circumstances until you had a car accident, because why waste your money on monthly premiums for auto insurance? You get a car accident, you get on your cell phone, call the auto insurance company and say, I'd like to buy auto insurance right now. I'm standing by my car that I had an accident with. And they have to sell it to you. And they can't charge you any differently than if you didn't have an accident. So that's the way it is in the United States. That's just the payment part. So in summary, at least when it comes to the payment part, before I get to that, I want to mention, now, people know economics know there's nothing, as Thomas Sowell famously said, there are no solutions, there are only trade-offs. So when it comes to health care, payment for health care, there are trade-offs, and one of them is rationing. Now, that's an area where the U.S. and Canada differ. So in the U.S., rationing occurs mainly by price. And like I said, when it comes to health insurance, it costs so much that some people decide, I'm just not going to buy it and waste my money on it. I'll wait until I get sick, and then they have to sell it to me. In Canada, rationing occurs by time. Since there's a set amount of money allocated, there are long queues. And that's the way healthcare gets rationed. So according to a recent report from the Fraser Institute, the wait time for a referral from a GP to a specialized treatment averaged 28.6 weeks in 2025. In the U.S., the closest comparable interval from referral to seeing a specialist is, usually around 2 to 4 weeks, though it varies by region and condition. So there's waits here in the United States as well, but not nearly as great a wait as there are in Canada. So the US tends to have shorter wait times, but relies more on price and insurance constraints to limit access, whereas Canada uses time as the primary rationing mechanism. So when it comes to payment, as I said in the beginning of this talk, the US system is a stitched together patchwork of different government run healthcare payment models. I like to call it Frankenstein's monster because you got all these different ways of socializing medicine all under one umbrella, as opposed to one way to socialize medicine. And when a lot of my colleagues and friends in the United States say, I don't want to have a socialized medicine system like Canada, I tell them, no, we have a socialized medicine system that's uniquely American. We don't have a free market health system. And I like to dispel people of that notion. But there are other ways in which Canada and the US are similar. So, for example, we have the Food and Drug Administration, the FDA, and Canada, their equivalent is, I think, called Health Canada. In both cases, we have a federal government agency that's a monopoly on the decision-making process that gets to decide what medications we're going to be allowed to have. They look at the evidence and they decide, well, we don't think this works for you, or we don't think this is different enough from a drug already available, so we're not going to let you have it. And if they decide to let you have it, they decide whether or not they're going to let you just have it and go and buy it, or whether you need to get a permission slip from another autonomous adult like yourself, who's a government gatekeeper. Another name for that is a licensed physician who could prescribe. And then they'll let you buy it, providing you get a permission slip from another adult like yourself who's a government licensed gatekeeper. The FDA does that. Canada does that. Now, in my book, we talk about my book, Your Body, Your Healthcare. I talk about our inherent right to self-medicate, which is a corollary of the right to informed consent. As autonomous adults, we have a right to decide what we're going to do with our own body, but apparently a federal agency, which is going to be influenced by both political considerations and special interest pleading, and oftentimes will be captured by the pharmaceutical companies that it regulates, that gets to decide for us and makes the risk-benefit assessments for us, not us. We can't make our own risk-benefit assessment. Only this agency does. So there's another way in which the U.S. and Canada have a lot in common. And finally, there's another way we have things in common. Both in the United States, this is a state level thing, and in Canada, it's a provincial level thing. We have licensing laws. So in order to be able to provide healthcare services to individuals, you have to get permission from the state to do so, and then you're regulated by a licensing board. In both the US and Canada, those state licensing boards are heavily influenced. In fact, were originally sought by the incumbent medical professions, and they serve as a way to keep out competition from the growing number of allied health professions that over the last 100 years or so have become very sophisticated and in many cases can offer a lot of the same services that physicians can offer. And that's called scope of practice laws. Now, I have much more experience with this in the United States, but in the United States, for example, in about 24 states or so, nurse practitioners, and there's a lot of empirical evidence suggesting that when it comes to primary care, they're basically equivalent in quality and maybe even have better bedside manner than physicians. But in about 24 states in the United States, nurse practitioners cannot practice independent of physicians. They have to work in a physician's office. In some cases, they could work in a separate place, but they have to have a contract with the physician for which they have to pay the physician to quote unquote supervise them, which might amount to nothing more than a monthly phone call saying, how's it going? It's sort of like, if you've ever watched The Sopranos, it's like when you hand an envelope with cash to Mr. Soprano once a week when he's expecting you to come by and visit. So same kind of thing. But it's not just nurse practitioners. There are a host of other fields that at one time were not as developed as they are now in the United States. There's a field called prescribing psychotherapists, where PhD or PsyD clinical psychologists do extra master's degree level training in psychopharmacology and do an internship, and they can prescribe medications just like psychiatrists can. And some instances suggest they're more conservative in the use of them. In 7 states, they're allowed, but in the other 43 states, the incumbents have fought allowing them to be able to provide those services to patients who want them. Canada has actually been good in one area. Alberta, I think, was the first province, but now Ontario and several other provinces have expanded the scope of practice of pharmacists, because nowadays most pharmacists graduating pharmacy school have doctor of pharmacy degrees, PharmD, which is 6 to 7 years of training. And they know an awful lot about drug interactions and dosing. In fact, in hospitals, we consult the hospital pharmacist all the time, and they're usually included when we're rounding on critically ill patients in the ICU, because we value their expertise on, a lot of those patients are on numerous meds at the same time, and we sometimes they give us advice on, maybe you want to remove this one because it's actually working against the other one. So we have them included on the team. So in Alberta, Ontario, and a few other provinces now, you can go to a pharmacist for a routine, self-limited problem like a strep throat or a UTI, or maybe an ear infection. And instead of having to take time off of work and wait for hours in a waiting room to see the doctor who's going to do exactly what they're going to do, because you've been through this before, you know what's going on, you could actually stop off at a pharmacy, which they're much more numerous, maybe on the way home from work, and not have to leave work, half a day, and the pharmacist could take care of it. And if that doesn't work, if that self-limited treatment doesn't work, the pharmacist will say, if this doesn't help you, then you better go see a doctor. So Canada, a few states now in the United States, the first one was Idaho, then Montana, and then Colorado. They've actually followed the model that was, I think the first province to do it in Canada was Alberta, but now Ontario and a number of others. And finally, a few states in the United States are starting to follow that example and do it here as well. But both Canada and the US, their states have these licensing laws which restrict entrance into the field. And if you frame it from the patient autonomy standpoint, they're basically, the state is telling us autonomous adults whether or not it thinks that the people we'd like to get advice or treatment from are good enough for us to get advice or treatment from. They get to decide, not us, whether this person is good enough for us. And of course, particularly the medical doctors, the incumbents are, all too anxious to argue to the state licensing boards that these other would-be entrants into the field are not good enough for the patients. It's not safe. We only have the interests and the safety of the patients in mind, not our own self-interest. Now, there's one area where the U.S. and Canada differ, and that's on what we call certificate of need laws. And I talk about all of this in my book, by the way. So certificate of need laws came about really in the 1970s, when Medicare and Medicaid had been about 6 or 7 years in effect, because they were passed in the 60s. And the open-ended nature of them really was stressing the federal budget. And Congress, and at the time President Nixon, realized, oh my goodness, this is costing a lot more than we thought, since they're not block granted like in Canada. They thought, I got an idea. Maybe if we have commissions that say how many beds you could have in a hospital, or how many CAT scanners you could have, or if you want to open up a new ambulatory surgery center, or an eye clinic, if we have a commission that says whether or not you can do that and restricts the supply, then that will restrict utilization and lower the cost to the government. So the idea here is that a reduction in supply will somehow reduce the price and the cost. Okay. Most people who are on this webinar probably are wondering if that makes any sense from an economic standpoint. Well, it doesn't make sense, especially when you have a third-party payer system, so that the end user, the consumer, is divorced from any price effect. So if something costs more because the supply is limited, but the demand hasn't gone down, in fact, it may be continuing to go up. And the reason it's going up is because the perceived cost to the consumer is zero or close to zero because the third party is picking up the bill. That's not going to work. And it didn't. So the federal government, though, in 1974, gave grants to states to set up certificate of need commissions. By the mid 80s, when Reagan was president, they realized this isn't working. Things are only getting worse, costing more. So, because you had increased, no restriction in demand, or maybe an increase in demand, restriction in supply, the price going up, and the third party payer, mostly the government, picking up the bill. So they repealed the act that gave grants to states to set up certificate of need laws. And several states, including mine of Arizona in 1990, eliminated them. California is another one. But to this day, 34 states, it was up before this year was 35, a state just eliminated, but 34 states still have them in place. Now, some to varying degrees, they may have it only for certain kinds of health services like nursing homes or whatever, but some states like Kentucky is a bad offender. Virtually everything. They finally repealed a certificate of need if you wanted to have a birthing center to have a baby. So in other words, if you want to have deliver your baby in your house, you don't need government permission. But if you want to have somebody come over to your house to have their baby, you need to get a certificate of need. So, and there are a lot of, you probably are aware, I'm sure you have birthing centers in Canada too. It's a popular thing. A lot of people prefer the environment. It's much more of a comfortable environment. It's also a lot of times more culturally matched to different groups of people, and they feel more comfortable. Well, so in my book, I give the analogy. Imagine if you had a certificate of need commission for restaurants, and you have this fascinating new concept. You think it's really going to work, and you hired a chef where you have a fusion of Mexican and Indian cuisine, and you created these new dishes, and you're going to have this interesting decor, and you want to open up this restaurant, but you have to go to the certificate of need commission, and the commission, which is either staffed by the major restaurateurs in your state, or if not, is certainly heavily influenced by them. They review your application and they decide, no, we don't think that's going to work. Nobody's going to be interested in that kind of concept. Plus, we have enough Mexican restaurants and enough Indian restaurants. A mixture of the two is not necessary. Denied. That's what happens in 34 states when it comes to if you want to open up an ambulatory surgery center, or maybe an independent freestanding radiology center where people can come and get their x-rays rather than having to wait in a busy hospital. There are these commissions. And usually it's the incumbents who fight to keep the certificate of need law in place. In fact, I testified remotely before the Kentucky legislature because about getting rid of their certificate of need laws. And the hospital association is the biggest supporter of it. And it's interesting. They weren't even trying to be subtle about their reason. They were explicit. So it's well-known fact that a lot of the ambulatory surgery centers could do a lot of things that are done at hospitals for a lot less money. So the system is less financially strained with ambulatory surgery centers. So they were arguing before the lawmakers that many of our hospitals are in rural parts of Kentucky where the majority of our patients are paid through Medicaid, we talked about earlier, and Medicaid doesn't pay us very well. And if we had to compete with an ambulatory surgery center, we'd lose enough business where it wouldn't pay for us to stay in business, and we'd have to close up. So please keep the certificate of need laws in place so we could block ambulatory surgery centers from opening. And when I had a chance to testify, I said, just like the hospitals in those parts of the state have mostly Medicaid patients, so do the doctors. And if I was to say to this panel, I don't think we should allow any other doctor to come into the state of Kentucky until a committee of Kentucky doctors decides that Kentucky could use another doctor. You consider me absurd, yet you seem to not consider it absurd when the hospital association says the same thing. So Now Canada doesn't have this, so this is an area where we're different. But that's because I think, to my understanding, and you can correct me if I'm wrong, but most of the healthcare facilities, hospitals, et cetera, are government funded, and if a new facility is going to open up, that's a decision made by lawmakers, not by people competing in the marketplace. So basically, that summarizes it. So both countries have socialized medicine. Both companies uh, uh, infringe on our autonomy in terms of what medications we can have and how we can get them. And both countries have regulations that restrict our access to different healthcare providers who may be trained to be able to help us, but we're denied the opportunity to do it. And I left out, but this wouldn't be healthcare system, although it contributes to healthcare problems. Both countries have drug prohibition, which is another way in which the government is saying, we're going to punish you. We're not going to allow you to put a substance into your body that we don't think you should be taking. And if you do, now the United States is worse than Canada in this respect, but if you do this, we're going to ruin your life and put you in a cage and make it so that when you get out, you have a felony record and you're going to have a hard time getting a decent job for the rest of your life. Canada is probably a little less aggressive there, but both of them infringe on our autonomy in that respect. So at that, I'll take any questions, and Matt, you'll field that, right?
Yeah, absolutely. Thanks so much, Jeff, for that talk. Reminder, many of you will already know this, but for asking questions, you can do it in one of two ways. If you want to raise your hand and I will call on you, can you ask your question yourself? Or if you need to put it in the chat, then I will read those and present those to Jeff as we go. See a question from George, and he's asking if my wife and I move to the U.S. as seniors to live near our son. He says, would we have access to healthcare? I'm going to maybe modify that to what would their access be healthcare like? So if a Canadian decides to come to Canada, what happens?
Well,
Oh, sorry, if a Canadian
United
decides to come to
States.
the U.S., yeah.
Well, if you're going to be a permanent resident, once you become a permanent resident, I may be wrong here, but I'm pretty sure, like if you have a green card, you're eligible for Medicare if you're a senior. But most immigrants, until they become permanent residents, are not eligible, according to federal law, for Medicaid. But they could pay for their own health care directly, or they could buy insurance. I know in Canada you could buy insurance for when you're like Lloyd's of London or whatever for when you're going to another country, and that's like real insurance, like risk adjusted, and you could get the coverage that you think you need rather than get a whole bunch of coverage that you don't need. But I live in Arizona. We get a lot of Canadian visitors, particularly in the winter time, and they don't have any trouble. In fact, a lot of them get their health care taken care of while they're here. I'm a surgeon. I've lost count of how many hernia operations I've done on Canadians during their winter visit to Arizona because there's no wait. You say you want the hernia operation, you agree to it, we schedule it, especially if you're going to pay me.
That's an interesting example because I know that a lot of Canadians who do spend time in the US, and especially seniors, will then sort of, monitor their time away because there's requirements of how much time they have to be in Canada to maintain access to or in their province to maintain access to their provincial healthcare plan. So I suppose in a way that's a market, right? They're going down, they're paying for the services on the market that they feel provide a good value to them, and things that they may not feel provide as good value for. They want to maintain their Canadian healthcare coverage, and so they're able to get those when they come back.
And I'll tell you something else. And a lot of Americans are figuring this out. If you offer, even Americans with insurance, if you offer cash pay, most healthcare practitioners are happy to take you as a patient and charge you a lot less than they will otherwise charge you. Because when they have a third-party payer system, uh, I do this myself. We're all guilty of this. I'm a surgeon. So if I want to get paid by the third-party payer, let's say $500, then the bill I send in, and if anybody's been a patient in the United States, you may see this, I'll send in a bill for, let's say, 1,500. And it's a negotiation. It's sort of like when you're buying a car, remember in the old days where the salesman would go step outside. He's actually just having a cup of coffee, but he said, "Let me talk to my manager and see if I can get the manager to come down in the price." And then they give you the price they were willing to pay in the first place, willing to charge in the first place. So it's the same thing. So if I want to get paid $500, I charge 1,500, and sometimes I get surprised. The insurance company pays me 800, which is $300 more than I was willing to accept. But if a person says to me how much for cash, and it also saves me money in having to have to pay someone to submit the claim and then wait and then sometimes have to answer questions. I give considerable discounts. And the same thing with drugs. I don't know if you have in Canada Good RX, but we have that here sometime. And there are several others. Mark Cuban set up Cost Plus. There are a lot of these online services where the insurance won't cover it, but for cash, direct pay, you can get a much better price on a prescription drug at the pharmacy than you would get if your insurance paid for it and then you have the copay. Because the third party has got a deeper pocket and it's a negotiation. So a lot of Americans are learning, like a lot of Canadians, they can get sometimes faster service and less out of pocket sometimes if they just say pay cash.
Yeah, I don't know if we have that Good RX program, but I do know that if you go to a pharmacy here, they will ask if you have coverage, and often if because drug coverage is not generally covered by the government, and if you say no, then often the price goes down when you're paying
Right.
over the counter. But if they're billing it to a third payer, and I think that third party payer is really the commonality that I think a lot of Americans think Canada has bad healthcare because of the government. A lot of Canadians think U.S. has bad healthcare because it's private or because of the insurance. And in my view, at least, a lot of these problems are sort of endemic to this third party payer. When
Yeah.
someone else is picking up the tab, it's not the same.
It's not just healthcare. How many people have had a car accident where they bring their car into the body shop? It's covered by the insurance, and the body shop guy says, "Was this damage to the front fender? Was that part of the accident? Because everything seems to be on this side of the car." And say, "No, that was a previous time. I never got it taken care of." He said, "Well, we could kind of make it where it's part of this if you want. Now that we got the insurance paying for it, same kind of thing. It's all."
Yeah,
It encourage people are responding to incentives. They're just acting rationally. It's not, I don't consider it to be evil in any way.
absolutely. Got a question from Niv in the chat. He says, given that all healthcare programs and laws in the U.S., both for employed and unemployed people, it seems that almost everybody actually has access to either affordable or subsidized healthcare. Is that correct? And if it is, why do we still hear about these cases of people facing massive medical debt?
Yeah, it is the case. There are certain situations of a medical debt. Mostly that's people who didn't have insurance because they chose not to, and then they show up, as an emergency. Like I talked to you about, 7% choose not to. There are also certain situations where under federal law, there's no caps. So there's no lifetime cap. In the early days, that most insurance would have like a lifetime cap of $2 million. After it's covered $2 million in medical expenses, it stops paying. But federal law prohibits that, so there's no cap in that. So it's largely due to people who don't have insurance and get a huge bill.
Wonderful. Thanks. I have a question for you, Jeff. Again, a lot of Canadians think that the U.S. has a free market in healthcare, as you've discussed and talked about many times, right? What the U.S. has is not a free market in healthcare. Could you speculate as to what a free market in healthcare might actually look like? And of course, I want to be cautious about pretending that we know exactly what the free market would provide if we had all that entrepreneurship innovation going on. But do you have some thoughts about what a true free market system might look like?
Yeah, actually, and I commend anybody who's interested in this. There's a book that my colleagues at the Cato Institute published, must be 5 years ago now, called "Overcharged: Why Americans Pay Too Much for Healthcare." But if you're Canadian, it's still everything in there makes sense for Canadians as well, and it covers all the moving parts, the FDA license, everything. Um, and they get to, so how do we get out of this mess? First, there is a role for, insurance, but insurance is designed to cover unforeseen, catastrophic, high cost events, right? So getting a wellness checkup or having a baby or purchasing birth control pills. These are not unforeseen catastrophic high cost events. The more regular, everyday, even getting an elective hernia operation. If you need new tires on your car, that's not covered by auto insurance. But every once in a while, you need new tires on your car. So, there's a role for insurance to cover those things that could wipe you out that you can't expect, and that's called catastrophic insurance. And if catastrophic insurance again was deregulated to the point where you could design what kind of insurance you want to buy for you, because if you're a single 30-year-old man, your healthcare needs are going to be different than a married 50-year-old man with 4 kids. So it's a whole different story, and you need to buy insurance that fits you. So but then the overwhelming majority of your healthcare purchases would be made direct, as we've already kind of talked about how it gets much cheaper. There's competition. Now, politically, how do you get there? In the United States, one of the approaches that's been advocated by us at Cato, Michael Cannon's written a lot about this, is what you may have heard of called health savings accounts. So we got Congress to enact that to some degree, but it needs expansion. So I told you about that tax exclusion where an employer doesn't have the health insurance your employer provides you is not taxable. The employer gets to deduct it. Well, one form of doing that is that in lieu of buying you insurance, the employer contributes that same tax excluded money into your personally owned and controlled savings account, that part of which you can invest and earn interest, tax exempt, just like a retirement account. And you could use that, and you can contribute to it as well. And you could use that money for health expenses, including maybe purchasing long-term care insurance when you're young, when it's cheap, purchasing that catastrophic insurance policy, which may be a fraction of the money contributed to the health savings account, since it's not covering all these bells and whistles that the federal government requires it to cover, or just directly paying for things. And so what you're basically doing, because politically it's very difficult to take away a benefit that's been in place for decades. So instead of saying, which would be ideal, if your employer provides you with the health insurance benefit that's no longer tax excludable, that's a taxable event. So you might want to ask your employer to say, instead of buying my insurance, why don't you just give me this salary, I'll buy my own. That's the ideal situation. That's politically very difficult to pull off. So instead you keep that exclusion in place and just say, I'll control the money and the choices, not you, Mr. Employer. So that combined with a catastrophic policy. But again, it's not just that. There's a lot of bells and whistles. We need the FDA. We don't need an FDA, and we certainly could do a lot of regulatory reform. It takes on average 7 to 10 years and $1 billion for a drug to get to market. And then by the time it does, the patent's almost expired, and all that research and development costs. The drug company has a few years to make that up, and they have to charge a high price because soon the patent expires and the generic companies come in to sell it, and the chemicals are actually cheap. All the cost is the research and clinical trials, et cetera. Licensing laws allow for much more of a pluralistic group of healthcare practitioners that we could choose from. So, I can go to the pharmacist for certain things. I can go to a nurse practitioner for other things, etc. So it's not just the payment system, even though that's what everybody thinks of it. There's a lot of moving parts. And I recommend that book, Overcharged: Why Americans Pay Too Much for Healthcare, by Charles Silver and David Hyman. They're both adjunct scholars at the Cato Institute. One is a JD, MD, who teaches at Georgetown, and the other is a professor of law at University of Texas at Austin.
Great. Thank you. And I posted a link to that book in the chat. Jacob, who I know is a graduate student in economics studying healthcare, is interested in your thoughts on whether private payers are better at identifying upbilling and upcoding, and mentions that he's thinking specifically in terms of what was uncovered with ABA fraud in Medicaid. And I'm hoping you might be able to tell us what ABA fraud refers to.
I think he's talking about the therapy for people with autism. It's interesting. The Wall Street Journal just did a big expose on that. And it's interesting that Jacob brings that up, because I'm working on a lengthy piece with a colleague of mine, Adam Omari at the Cato Institute, who's got a PhD in psychology and neuroscience, and had a very big op-ed in about a month ago in the Washington Post called "The Myth of the Autism Epidemic," and we're working on a piece together. Yeah, private payers respond to, rather, private providers respond to incentives, and it's it's the better we, and I've written articles about this too. There's a tendency for us to what we call upcode. The more diagnoses you can attach to the patient's chart, the better a code you can use to bill the third party payer, which is oftentimes Medicare or Medicaid, or the government designed private insurance company. Like I say, it's really not insurance, it's just administered by an insurance company. And that'll get you better payments. So there we respond to incentives to kind of to almost medicalize anything. So there've been times like I say, I'm still practicing as a surgeon, and I'm looking at the electronic record sent over from the referral doctor's office. And I'm about to go in and see a 35-year-old guy with a hernia, and seeing this whole list of medical diagnoses he has, including uh, if he's a smoker, then all of a sudden he's got tobacco use disorder as a diagnosis, because that's a bill, that's a diagnostic code. And I'm getting ready to walk in the room to see him, and I'm thinking, maybe I shouldn't operate on him. He looks like he's a medical basket case. It's probably too risky. And then I see this healthy specimen, and I start going over his diagnostic. He's not even aware of half of his diagnoses that are in his record. So that's what happens. We're seeing the same thing with autism. If you read, I recommend Adam Omari, Omary, in Washington Post in February, "The Myth of the Autism Epidemic." But we're working on a paper together. Not only has the diagnosis changed over the years so that it's widened from what was one time called childhood schizophrenia when I was a medical student to now autism spectrum disorder, which includes a whole lot of different types of people, and it's very subjective too. So that to come up with most psychiatric and psychological diagnoses are very subjective. If you look in the Diagnostic Statistical Manual, for a lot of diagnoses, it would say to have this diagnosis, you need any four of the following nine symptoms. Well, you're the clinician, and you're trying, yeah, I guess this one counts, but not that. So it's very subjective. But if you know that the more you find it, the more you get paid. And not just that, we have programs set up on state and local and federal level where schools get grants for ABA programs for children with autism, and you want to justify that grant money coming. So there's an incentive for school psychologists and school counselors to screen children from possibly being on the spectrum. And sometimes teachers are also told to be on the lookout. And if you think the child in your class may possibly be on the spectrum, ADHD is another one. Refer them to the school counselor, and they'll kind of screen them. So to answer Jacob's question, yes. The answer is yes.
Right. Jacob also has a follow-up. He's curious how much time you spend, he calls it playing claims ping pong, which I take to be just sort of, having to submit stuff and resubmit stuff with insurers. Is this something that takes up a good amount of your time or time of the people that you work with?
Takes a lot of time of people I work with.
Yeah.
Most of the time, my practice now is a pretty large practice. We have a lot of doctors and staff, and we have about four people working just in the billing department, and they're the ones who handle all of this. But I could tell you at the hospital, because as a surgeon, I have to go to the hospital to do a lot of my work, and on the hospital record the hospitals get paid by the third party payer based on what's called a diagnostic related group, or DRG. And again, the more health problems, the better the payment, because you're a more complicated case. And I can't tell you how many times I've gotten an email from the people in the hospital billing department saying, Dr. Singer, we noticed that this person you did a gallbladder operation on, they also have high blood pressure and multiple sclerosis. Could you add that to the diagnostic list? Would you do that for us? Because they're not allowed to. And I'm thinking, well, that wouldn't be lying. They do have that, and I don't want to be difficult. even though it had nothing to do with what I did, because it was an elective gallbladder operation.
Mhm.
But I'll say, yeah, sure, no problem. And that's because they're looking to be able to upcode their bill for hospital payment. And they have a whole team of people just working on that all day.
Yeah, yeah, yeah. I think it's interesting when people talk about, free market healthcare, and sometimes that free market bit matters, I think, a lot. Not just the market in healthcare, which, you guys in some sense have, but how different it would be to have a healthcare system where you walked in and, you could maybe see a price list on the wall without all this negotiation of, what
I'm glad you
applies and
brought
all
that
this
up. We
sort of
do
stuff.
have a total free market when it comes to cosmetic surgery and LASIK eye surgery. And lo and behold, just like every other thing in the market that is free, prices tend to come down over time. So if you want to go to a cosmetic surgeon to, let's say, get a facelift or a augmentation mammoplasty, first of all, you could shop around, and the plastic surgeon will give you a price. There's no surprise billing because it's usually bundled. The plastic surgeon will say the price includes my surgery, the fee from the surgery center where we're going to do this, the cost of the implant, and the anesthesiologist fee. You pay me, and then I'll distribute the money to the different payers. Same thing with eye surgery, LASIK eye surgery, which is usually not covered by insurance. I remember when it first came out, it was something like $5,000 to get the LASIK eye surgery. Now it's a few $100s. Competition does that. And there's a place in Oklahoma City called the Surgery Center of Oklahoma. You can go online. I think it's surgerycenterok.com, I think. I know Keith Smith's the anesthesiologist who created it. It's a private, they take no insurance, cash only surgery center. And if you go on a drop down menu, it's amazing because there's a whole bunch of partners in this. They have an overnight stay capacity. And if you look, it says our procedures and if on a drop down menu, and it tells you the total cost, including facility, any implant if necessary, surgeon, anesthesiologist. And he got together all these different specialists who are partners in this place. And he said to the orthopedic surgeons, for example, I need you guys to come to agreement on what your cash price is going to be for the list of procedures you're going to do here. I need you ENT guys similarly to come to an et cetera, et cetera. And they are so affordable that the hospitals in the area were trying to shut them down unsuccessfully. And then the city of Oklahoma City, which is self-insured, told their employees, if you need elective surgery, we'll pick up a larger part of the bill. You'll have a smaller copay if you go to the Surgery Center of Oklahoma. And some employers from around the country find it saves them money to fly their employees from, let's say, Seattle, Washington to Oklahoma City to get this done than it would be just to have it done there in their hospital.
I'm glad you brought up that surgery center because I find that fascinating. I'll put a link in the chat to a podcast interview that Keith Smith does with Russ Roberts on Econ Talk. I find that fascinating.
Yeah,
I have a question about that.
that gives you an idea about what a free market in healthcare would be like.
Yeah, yeah, I think it's great. So the podcast I see is now 7 years old. There's this example. Are you aware, are other people trying to copy that model? Should there be like a free surgery center of Minnesota and Arizona and all these places?
Well, I've gotten to talk to Keith Smith. In fact, he's participated in a couple of events I've had. He's actually traveling around the country trying to, consulting to help other groups in other parts of the country set similar ones up. So I don't know the latest on that, but I remember a few years ago he was in Charlottesville, Virginia to help a group there set one up. So I have to assume there are others setting this up.
That's great. I think we have time for one more question. Avi in the chat asks, what country has the most laissez-faire healthcare system?
I'm not sure. That's a really good question. I haven't really studied comparative health systems very much. Uh, from what I understand, I think Singapore probably is one of the closer ones to that because in Singapore, the only problem I have with it, it's mandatory, but that health savings account concept I was discussing, they actually have money taken from your paycheck and deposited into a health savings account. You don't have a choice. That's the part I have a problem with. But then that money is used to get health to pay for your health care. And I think, people can use a portion of that to purchase catastrophic health insurance. So I think that and I may be don't hold me to this because I read about that a while ago, so it may have changed. But to my knowledge, and this is not the don't take this to the bank, but probably Singapore.
That's great. That's similarly, I'm not an authority on this, but I have heard Singapore mentioned as one of the models that Canada maybe should pursue. And one of the things that I think many of us Canadians find frustrating in discussions of healthcare is anytime there's change brought up, the backlash is, well, we don't want to be like the US. And of course, there are many countries that are not the US, Singapore and Switzerland and many other places that have different models of healthcare. And I suspect we're not going to go to the free market utopia that you and I might wish we would in Canada, but there are also other places that are better than we've got, perhaps better than what the U.S. has, and we could be looking to those models.
Yeah, we just like I said to you before we started, uh, the United States has a schizophrenic type of socialized medicine.
Yeah, absolutely. Well, thank you so much for joining us today. It was great to hear about how the similar systems are more similar than we think they might be. I'm going to repost the link to our book draw one last time and encourage anyone who hasn't yet done so to enter that book draw for a free copy of Jeff's book. And if you don't win the free copy, then I hope you will purchase a copy and check that out. It's good stuff. Jeff, thank you so much for joining us today.
Thank you. It was a
Wonderful.
pleasure.
Thanks, everyone. Have a great rest of your day.
Bye bye.